Thank you so much, Mumbai. And I would like to also thank the Zambia Ophthalmological Society and COEXA for giving me an opportunity to interact with all of you. I hope I'm audible to all. Mumbai, am I audible?
Yes, I can hear you. You are audible.
Okay. Okay. And the slides are visible?
Yes, slides are visible.
Okay. So, Mumbai, just one clarification. Is it a paid webinar?
No, it's not a paid webinar actually. So I forgot to mention that COEXA is the Regional College of Ophthalmology for Eastern, Central and Southern Africa. So the headquarters is based in Nairobi. So we are using their platform and they are the ones managing this because they offer CPD points. So we have one of the administrators here who is, I think, in attendance, Vera.
Okay. So anybody with these credentials of the ID and password can log in and see, right?
Yes, please. So everyone can participate. We are able to host up to 500 participants.
Okay, that's fine. Okay, so the topic for today's webinar is cerebral visual impairment, and it's a very huge topic. And initially I thought that it's kind of a seminar where there would be multiple speakers, so we kept a series of topics. But then later I realized that no, it's only me. So it will not be possible to go through each aspect of it in depth, but we would just try to have an overview, and to go into the depth of any particular entity, probably we need to have another session. So at the outset, I would like to thank all my mentors who have been teaching me about CVI since years. First and foremost in this list is Professor Gordon and Dutton from Glasgow in the UK, Professor Leah Huvarinen from Finland, Professor Elisa Fazi from Italy, and Dr. Linda Lawrence from the US. These are some of the references which you can use, and the first in this is this red book, which is written in a very simple language, meant for professionals of all kinds who deal with children with brain injury. Vision and brain is more into depth, so it is more for teachers who handle children with multiple disabilities. But yes, it's a good resource for parents and medical people as well. Cortical visual impairment by Christian Roman Lanzi is more of a special teacher-oriented approach. And this cerebral visual impairment in children by Joseph Zeal and Gordon Dutton is basically a neuropsychology-oriented approach. These two websites, the CVI Society and CVI Scotland, these are extremely useful websites basically for families. But there is a lot that even other professionals can learn from that. And this book by the National Institute for the Mentally Handicapped in India, they have come up with this a very simple booklet for any child, basically infant and toddler with visual impairment. So what kind of vision stimulation activities can be done depending on the vision skill that the child has. I have sent this booklet to Mumbai and he can circulate it to all of you. So these are some of the resources and the people from whom I have learned whatever I'm going to present now. So these are the four objectives of this presentation. First is to understand what is CVI and why is it important to us. Then to learn how does brain see, what is the role of ophthalmologists in CVI, and then go on to assessment and interventions of low functioning CVI and high functioning CVI. So first and foremost, what is CVI and why is it important to us? So we would look at the definition, the spectrum, and the epidemiology. So it is a verifiable visual dysfunction which cannot be attributed to disorders of anterior visual pathway or any potentially co-occurring ocular impairment. It's a verifiable visual dysfunction. It means that it can be confirmed and reconfirmed on multiple occasions by different people. It cannot be attributed to disorders of the anterior visual pathway. That means ocular examination doesn't explain the vision. due to damage or malfunction of visual pathways and visual centers in the brain, specifically those posterior to the lateral geniculate body. So there is a certain history or a demonstrable damage on the neuroimaging to the visual pathways and visual centers, especially those which are posterior to the lateral geniculate body. And often these are associated with abnormalities of eye movements. So oculomotor abnormalities is an essential component of CVI. So these are the three essential components of CVI. Number one, there is a definite visual dysfunction and the eye examination cannot explain it. Number two, there is damage to the visual centers in the brain. And number three, often these are associated with abnormalities of eye movements. You would often see these two terms being used, cortical visual impairment and cerebral visual impairment. We feel that the term cerebral is more comprehensive because cortical just refers to the gray matter of the brain. But if we look at the causes of CVI, more often the problem is subcortical, and the most common reason of that damage is periventricular leukomalacia, which involves basically the white matter. So cerebral is a more appropriate term. Now CVI is not just one entity. When you say that a child has CVI, that doesn't really mean anything. We need to be more specific about what is the actual visual difficulty that the child faces. It's just like a patient has a cornea problem and that is why he cannot see. But what do you really mean by cornea problem? Is it corneal edema? Is it corneal scar? Is it a corneal tear or dystrophy, degeneration? What is it? We need to be more specific. So when you say that the child has CVI, all that it means is that the site of the damage causing visual impairment is in the brain. That's it. But it doesn't say what exactly the child is facing. So it's like an umbrella term. And under this umbrella, we have several entities. One can have just a loss of visual acuity. Again, because of a non-ocular cause, because of damage to the occipital lobe. One can have a visual field defect. One can have visual field inattention, poor contrast sensitivity, oculomotor issues, visual agnosias, visuospatial difficulties, motion perception difficulties, visual inattention. So all these terms collectively comprise of CVI. And we need to be specific when you say CVI, what is it among these that bothers the child the most? Now, CVI is a spectrum. On one side, we have a child who cannot even look at the light. That is called low functioning CVI. And on the other side, we have a child who can see well. If you just observe the child like that, it would appear as if the child is able to use his vision very well. But he is unable to process the visual information and use that information properly to execute a task. That is called high functioning CVI. So these are the two ends of the spectrum. But it doesn't mean that if a child has low functioning CVI, he cannot have high functioning CVI. Or a child with high functioning CVI cannot have low functioning. Many times they coexist and they overlap. So it is important to understand that a child with low functioning CVI can also have vision processing related issues. Now, if we take developed countries, CVI is the commonest cause of visual impairment in children. In the developing world, we had cataract, glaucoma, ROP as the most common causes of visual impairment, which still continue to be so. But because of increasing number of premature babies who are surviving and babies who had stormy perinatal period with brain injury, they all are surviving. And because of that, CVI is coming up as a cause of visual impairment in developing world as well. What we have seen in India is that many of the children who come to our clinics with brain damage, majority of them are very young, less than 2 years old, and they have profound visual impairment, and they have delay in several other areas of development. What we call as high functioning CVI, where the child's primary visual functions are good, but they are not able to process that vision very well. Such children in our scenario are very few, and that is basically because they come to our clinics, but we are not picking them up. So the implications of this are, we as ophthalmologists have to equip ourselves in assessment of young children with severe visual impairment and multiple other developmental challenges. As ophthalmologists, we can do only little. So we need to develop a team who can handle other issues. And we have to find ways of picking up high functioning CVI in the community. So to summarize, CVI is an umbrella term and it is a spectrum. In developed world, it is already the commonest cause, and in the developing world, it is coming up. Now the next objective is, how does brain see? Before actually going to the different clinical manifestations of CVI, one needs to understand how does brain process vision. So first we need to have an overall idea about how does the brain really function. And I really love this model, which is given by Professor Gordon Dutton in his book called Vision and Brain. So he basically divides brain into three parts: the front, the middle, and the back. The front part basically serves the intellect, conscious, thought, and choice. The middle part of the brain serves language, body movement, and sensation. And back of the brain serves visual recognition and visual guidance of movement. So to summarize, front of the brain thinks, middle of the brain does things, and back of the brain sees things. Now, the affected children, depending on which parts of the brain are affected, can be considered into three groups. In the first group, where the front, the middle, and the back are affected, the child has impaired intellectual function, impaired motor function, and there is visual impairment. Such children are called as MDVI, that is multiply disabled and visually impaired children. When we have the middle and the back affected, such children are typically they are called as cerebral palsy. Because of the motor involvement, we have spasticity or flaccidity, and they also have accompanying visual impairment. And the third group, where only the back of the brain is affected, such children often have low vision, or sometimes they may just have perceptual visual impairment, meaning their visual acuity may not be that bad, but they are not able to process that vision very well. And many of the children actually may be in the mainstream school and not in the blind school. So that is how we can remember the different parts of the brain and the different categories of children with CVI. Now, what do you see in this picture? If you just look at the picture, it appears as if there are just dots of black and white color. It doesn't make any sense. But now, does it make sense to you? It looks like there is an animal which looks like a dog. So, seeing and vision is not the same. What we take in with our eyes is just a jumble of a lot of information, but it is the brain which makes sense out of it. So whatever happens outside, it needs to be constructed in our minds. So if we actually see, eyes just send in some jumble of information, and it is the brain which helps us see. So we actually see with the brain. Now, what does brain really do with this information? So this three-level approach really is helpful to understand and remember this while we deal with a patient. So when visual information is received by occipital lobes, it is basically processed for few primary functions, that is visual acuity, visual field, color perception, and contrast sensitivity. Now, when this occipital lobe is affected because of any reason, like say hypoxic ischemic encephalopathy causing occipital infarcts, this child's acuity function would be affected, so there will be issue with clarity of vision. Field may be affected, so they may have visual field defects. Contrast may be affected, leading to poor contrast sensitivity. Close to the occipital lobes, we also have a part of the middle temporal lobe called as MT, which is responsible for motion perception. So the brain actually reconstructs all these small frames which are taken at very little time interval and reconstructs them into motion. And this particular part is responsible for that motion perception called as MT, that is the middle temporal lobe. So when that part is affected, a person will have defective motion perception. At second level, that is posterior parietal lobes, this part is called as the mapper and the doer. It is also called as dorsal stream, also called as the wear system. The principal function of this level 2, that is posterior parietal lobes and the dorsal stream, is to create an internal three-dimensional map of external visual world in our minds. So it is this posterior parietal lobes and dorsal stream which tell us where things are in relation to each other in the space, where things are in relation to our body, where our body parts are in relation to each other. All this topographic organization of the external world is constructed by these posterior parietal lobes in our minds. And the major purpose of creating this three-dimensional map is to facilitate visually guided body movements. All the movements that we do in our day-to-day activities are guided by this map. If this map is not accurate, our movements cannot be accurate. And what needs to be remembered about this is that all this mapping and calculations and movements, they happen at subconscious level. We are consciously not aware of how is the brain doing this job. And the purpose behind keeping it subconscious is that if we have to consciously think about this every small thing that makes our movements precise, we will have no other job left to do. So that is why God has kept it at a subconscious level. The other function that this dorsal stream does is giving selective visual attention. We see a lot of things in our visual environment, like in this room, but at a given point of time, we are able to focus our attention to only the object of interest or the person of interest. And this remarkable ability of giving selective visual attention is very, very important for us to perform our task properly. And this helps us avoid overload of every detail of every object, because it is not possible to perform a task when our attention is so divided. So what will happen if the dorsal stream posterior parietal lobes are damaged because of, say, an infarct? The person will have difficulty in processing complex visual scenes. So they cannot really focus on the object of interest. That is called simultanagnosia. That is inability to focus on the object of interest. They may have difficulty in visually guided movements because the mapping is not accurate, movements cannot be accurate, and that is called optic ataxia. And impaired visual attention. They cannot focus on a task which is visually demanding. So if you ask the child to read for a while, in maybe a 5 minutes time, the child gets exhausted and cannot do it anymore. That is called impaired visual attention. Or if such a child with impaired visual attention is kept in a busy classroom like this, where besides the blackboard, there is so much information, but the child can take in only one object at a time. The child looks at this image of ice cream, which is quite appealing to the child, and then the child is lost. He cannot notice the blackboard, he cannot notice the teachers, and his entire attention is drawn towards this ice cream. So such children are often labeled as people with poor concentration and some kind of learning disability. Now, posterior parietal lobes send all these calculations to the frontal lobes. Frontal lobes, as we said earlier, is the part which thinks and takes decisions. So from all this imagery that it receives, it chooses the object of interest. Yes, from all these 100 things that I see, this is the object is of my interest. Then it helps eyes and head move towards the object. To look at the object, you have to move your eyes and head towards it. And it decides to make an action that, yes, I want to pick up this particular object. So that decision comes from the frontal lobe. So these posterior parietal lobes are always in sync with the frontal lobe. Then we have level 3, that is temporal lobes. It is also called as the what system, or I also call it as the Google. Whenever you look at an object or a person, that image from occipital lobe goes to the temporal lobes. And then what happens at the temporal lobe? Temporal lobe searches all its stored images which it had stored over a lifetime, and then tries to match that image with those million images, and then tries to make a match. Oh, this person matches with this person, it has to be him. So that is how the matching happens. And it's just like Google. When you want something, you just type and it searches and throws you the results. The temporal lobes also work in a similar way. So they help us with recognition of faces, objects, shapes, and routes. So it's actually like a library where we have all these things stored, and whenever there is a new object coming in, it is matched with all these. Now, though we say this is level 1, 2, and 3, it doesn't mean that one is above the other. They all work in sync. Okay, so the temporal lobes will tell what is it. The posterior parietal lobes will tell where they are. Then this whole information goes to the frontal lobe, which thinks and decides what is to be done. Once that decision is taken, that whole information comes back to the motor unit, and then an action is executed. So when a person has ventral stream dysfunction, they may have difficulties with I don't know why they may have difficulties with facial recognition, also called as prosopagnosia. They may not be able to see a person, they may not be able to recognize a person by seeing, but they can recognize only after they hear that person's voice or the smell or a particular walking style or something, but not by looking at the person. Various agnosias like difficulty recognizing color, shape, letters, objects. They cannot remember the routes. Simple things like if you drop a child at the gate of the school, he often has difficulty in finding where is his classroom. So that is called topographic agnosia. So all these agnosias are features of the temporal lobe or the ventral stream dysfunction. So to summarize, occipital lobe is the printer, posterior parietal lobe is the mapper, and inferior temporal lobe is the Google. When there is, and occipital lobes basically process visual information for acuity, field, and contrast. The inferior temporal lobes help us with the recognition of faces, objects, and routes. Posterior parietal lobes help us focus attention on object of interest. They create a 3D map of visual world, and they plan visually guided body movements. When these parts of the brain are damaged, if the occipital lobe is damaged, we have loss of clarity, visual field defect, loss of contrast. When ventral stream or the temporal lobes are affected, we have issues with recognition of faces, objects, routes. When dorsal stream, that is posterior parietal lobes, are affected, we have issues like simultaneous agnosia, impaired visually guided movements, and poor visual attention. So when we look at the neuroimaging of the person, and we know that, okay, these parts of the brain are damaged, then we should be able to have an idea about what could be the child's difficulties based on the damage seen on the neuroimaging. Now, quite often, it is not possible to have neuroimaging in many of the children that we see in the developing world. But if we really do a good examination, by findings of the examination, we can predict where is the damage in the brain. But one should always remember that if the damage has happened at a very early stage of development, then there could be neuroplasticity. So if a part is damaged, its function can be taken over by another intact part of the brain, and that is called neuroplasticity. So the findings of the neuroimaging and what we see clinically, they may not always match if the damage has been very early. But nevertheless, we cannot underestimate the importance of knowing the site of damage. So this is the summary of what happens inside the brain once visual information reaches occipital lobes. We must not forget few other things that contribute significantly to processing of vision, and that is the vestibular and proprioceptive systems. It is the vestibular system which gives us a frame of reference. I'm sitting on this chair erect with my head looking straight. Where am I in relation to space? Where is my chair? How is my body sitting? Where am I? Where my body parts are? That sense of balance. All that information is precisely calculated by the vestibular and proprioceptive systems. So just having this intact, these three parts of the brain is not enough for visual processing. Many a times, It is these vestibular and proprioceptive issues which cause more visual disability. And this doesn't come under the realm of an ophthalmologist, but more of an occupational therapist and physiotherapist. Those are the people who deal with these issues well. So one must have a well-trained physiotherapist or occupational therapist to identify and treat issues related to this. We said that frontal lobes play a significant role in thinking and decision making about the actions and processing the information which flows to it from the posterior parietal lobes. So we cannot underestimate the importance of good cognition to perform a vision related action. And to translate any vision information into a motor action, one needs to have an intact motor system. So it is an interplay of all these things that help us see and use that information for any meaningful activity. So this frame of neural processing of vision should always be there in our minds when we deal with child with brain damage. Now coming to the next objective, that is to understand what is the role of ophthalmologist in CVI. Now the challenge in developing world is that we have pressure to see loads of children. I don't know why, yeah, all right. So we have loads to see and we have pressures to earn revenue. We have limited time and there is no training to deal with children with brain damage. So with this kind of a background, what is it that I can do for children with CVI and how? Because to examine a child with CVI, it's going to take hours. So who will take care of other children who are waiting? And if we just keep on seeing only children with CVI, how is the whole enterprise, the eye clinic or the hospital going to sustain? And I have limited time. I don't have any training. Then what is it that I can really do for the children and how? So we have tried to divide what one can do as ophthalmologist into 3 headings. That is thing that one must do irrespective of whether you are pediatric ophthalmologist or cornea surgeon or whether you have training in dealing with children or no. These are a few things that one must do as an eye care professional. Then the second set of things are, it would be great if one can do. And if one really wants to get into CVI, there are a few things which are ideal to do. So what are these? Now, before going into those details, there are a few things that one need to understand. One is that CVI is a medical condition only till a diagnosis is made. After that, it is completely a habilitational and educational condition. Meaning, CVI cannot be treated the way we treat glaucoma or cataract. There is no surgery, there is no medication which is going to cure this problem. All that we have to do is habilitate the child looking at the strengths and how we can facilitate day-to-day tasks and development of the child. So it is more of an educational condition. And unfortunately, this part is not emphasized in our medical training. And how far one wants to go in helping in the children is up to us. Now coming to must do, the first and foremost is diagnosis. This is very crucial because it is only a medical doctor who can make a diagnosis of CVI. Does the ocular examination explain the vision or no? If no, think of CVI. Because only when a doctor makes a diagnosis, then all the machinery, the mechanism, the different professionals come into play to help the child. If doctor only says that, we can't really explain, but I don't know what is it, so let us wait and watch. So very precious opportunity to help the child at a young age is lost if we do not make the right diagnosis. This especially happens for children with high functioning CVI. That is, children who have reasonably good acuities. And if you just see them in their day-to-day activities, it looks like they have good vision. But they have few specific difficulties, like they are not able to recognize familiar people. They keep bumping against things on the floor. So neither the parents nor the ophthalmologist are aware that these symptoms could have visual origin. And in such cases, the cornerstone of diagnosis remains in good structured history taking. One must pay attention to what parents say for making a proper diagnosis. And some of these complaints that parents say are not the usual ones that we come across as ophthalmologists. So whenever people talk to you about these things, be cognizant that it could be CVI. Child seems to see well sometimes and sometimes not so well. So that is why they say, oh, I saw that child yesterday, he was walking around nicely, he went home, he was playing. What do you say? He has this vision problem? No, probably he's faking his vision loss. Limited span of visual attention. If you make the child read something, he's not able to. But you'll ask him to go and play, he plays for hours with his friends. So an activity which is demanding for vision, they cannot really concentrate on it for long. Making use of other senses to understand something other than vision. To do anything using vision, they take more time. They often have problems with eye-hand coordination. Any activity where he has to use vision and hands, like placing a ring on the ring tower or putting a coin in a piggy bank, they often have difficulties in solving puzzles. Difficulty in recognizing people by seeing. And we think, oh, yesterday only you saw that person, how can you forget it right now? That is because their temporal lobes are not processing faces very well. Difficulty in understanding language of facial expressions. Can't you understand that I'm angry? Can't you understand that I am upset with you? And they just don't get those expressions. Difficulty in seeing moving things and judging distances. If somebody throws a ball at them, they just keep looking around and can't just figure out where is the ball. Difficulty in judging distances and depth. While crawling, walking, they often tend to fall. They often have difficulty in climbing the stairs, especially walking down the stairs. Difficulty in getting oriented to a new surrounding. If they go to a new church or a new function hall or a new school, a friend's house which is unfamiliar, they find it very difficult to get oriented. That's because their posterior parietal lobes are not working very well. So if you see such unusual complaints, look at something called as crowding ratio. That is the ratio of best corrected visual acuity with linear optotype versus visual acuity with single optotype. That means if you show the child the whole line at once and make him read versus what is the visual acuity by showing single letter at a time, and take the ratio of these two acuities. If this ratio is more than 2, that is suspicious of dorsal string dysfunction. That means the child is unable to process multiple letters at the same time, but if you show them one by one, he's able to get them. Suppose a child has visual acuity of 20 by 125 with the whole line shown at once, but if you show single optotype at once, they improve to 20/30, so the crowding ratio is 4. So it is quite possible that the child has dorsal string dysfunction, and that can explain some of the symptoms that you may have come across. It is important to remember that ocular and cerebral visual impairment can coexist. So if you see a child with cataract, it does not mean that he cannot have CVI. Or if you see a child with dyspallor, he cannot have CVI. They all can coexist. So say after doing a cataract surgery for a child, the visual recovery is not as you expected, think of CVI. You gave glasses. Despite good compliance with the glasses, the vision is not improving. Think of CVI. So the way you would habilitate a child with just an ocular impairment versus one would habilitate a child with ocular and cerebral visual impairment is way different. So it is very important to understand this coexistence. The second thing that we all must do is identify the treatable issues. And one of the most common underdiagnosed treatable issue in these children is poor accommodation. Many of them are not able to accommodate well, so they are not able to see things at near very well. And one simple test that can help us diagnose this is dynamic retinoscopy. So while showing the child a bright object at near, we look at the retinoscopy reflex. Does the reflex become neutral or it goes against? That indicates that the child is able to accommodate well. But if the reflex remains as a with movement, then probably child is not able to accommodate well, and we need to support that accommodation with a additional plus correction that one would give for a presbyope. Many a times it is not possible to do dynamic retinoscopy in such young children for several reasons. So for such children, we keep some ready-made plus glasses ready in the clinic, and we just make that child wear those glasses. Like over here, the child just refuses to look at the face without glasses, but after wearing glasses, suddenly he has become very attentive. And the reason is he was not able to accommodate, so he was refusing to look at the face. But after wearing the glasses, suddenly he's able to see the face. So that is how one can recognize poor accommodation and treat it. Cataract, high refractive errors. These are simple treatable problems. Quite often it is thought that children with brain damage, even if you intervene for cataract or refractive errors, they're not going to benefit from it. And that's a big, big misconception. If we do not treat these treatable problems, we are adding an avoidable disability on top of an existing severe disability. So one must never predict what is going to happen in the future, but if there is something treatable, we should go ahead and treat it. Counseling at the first visit after making a diagnosis goes a long way in terms of what parents are going to do with that child. If we don't show them any hope in the first visit itself, then they lose the hope and they do not follow with you. So we need to talk about the strengths. And most parents, ever since the child was born, have never heard anything good about their child. But there is always something good that you can talk about the child. So emphasize on the strengths. I always tell the family that child with CVI is very unlikely to be completely blind because the end organ, that is the eye, is intact. And there is a big part of the brain, as we just saw, which is involved with visual processing. And there is no disease of the brain which knocks off whole of this brain processing mechanism for vision. So if a child has CVI and the eye is normal, it is quite possible that the child has some residual vision in some way. It is for us to find out how the child sees and then encourage use of that vision. This is a lifelong condition. Don't think that by coming here for a few months, the child is going to get cured forever. The aim of our interaction is to understand what is the residual vision, how can we nurture it, and the people who can really help the child is you yourself. So that is how we have to make them aware of their role and empower them with the necessary information. Many a times they have some systemic issues which influence vision very significantly, like a child who has, say, uncontrolled epilepsy. How much ever vision intervention you do, if the epilepsy is not under control, the vision is not going to improve. So if they are not getting enough guidance or they do not have resources to control that systemic issue, we have to guide them. So that is about counseling in the first visit. Then comes the referral. There are a lot of things in these children which are beyond our training, but people in vision rehabilitation, physical therapist, speech therapist, occupational therapist, they all can handle these issues. If we do not have them in our hospital, we need to refer them wherever they are available. And one should always appreciate people involved, give them credit, and that's how we build a team spirit. The other thing we must do is to save the children from pseudotherapies. A lot of people are actually looking for quick fixing, that the doctor or any therapist has to do something magical and few days time my child should be okay. Not many are open to go for these long-term sessions of things that they have to do themselves. So that is why these treatments like stem cell therapy, hyperbaric oxygen therapy, traditional medicine, they all have come up and people end up losing a lot of time and money, and also some of them cause potential harm. So we need to make them aware that, okay, if they want to go for those treatments, they can, but at the same time, they must continue the simple approach of KISS, that is keep it slow and simple. It is going to take time, but it can make miracles happen if we really understand child's vision and what to do with it. So these are all must do things. Coming to what is good to do. If you are really interested, one can go into something called as functional vision evaluation. That means how does the child really use his vision for his day-to-day activities? So to see how big should an object be, it should be held at what distance, it should be held in which direction, what should be the contrast of that object, what should be the color, how long you need to hold it so that the child can see. So finding out all those parameters and then checking how this information can be put into child's day-to-day activities, that is called functional vision evaluation. Traditionally, as ophthalmologists or pediatric ophthalmologists, none of us are taught this subject, but it is something that if someone is interested, can certainly learn and use. It's very important because as vision professionals, we are the best people to understand vision and put it into practice. But this cannot be done in a busy clinic because it at least takes 45 to 60 minutes to see a child for all these parameters. And it may be possible that you cannot see everything in one visit. You may have to put multiple visits. So one has to create time for this evaluation. Now, how do you create time? I'm so busy. When we see a patient who needs a surgery in the clinic, do we do it on the same day? Many a times it is not possible. We do it on a particular day which is scheduled for surgery. So if this is a priority for us, we can also schedule a child for a CVI examination on a particular day. When you don't have the pressure of seeing the regular OPD, you can put a few children for that day just for CVI examination and see them. How often you want to do it? It depends on the caseload that you have and how much you really want to dedicate your time. It could be say half day in a week or a half day in 2 weeks, or it can be twice a week. It depends on what is your focus and priority. It would be really ideal if one can build all the services under one roof. We just said that the child requires different therapists, and to visit all these therapists on different days itself becomes a source of problem for the child and the family. Most of these therapists do not know much about child's vision because they are not trained in vision. But the paradox is that most of the tasks that they advise for the child's treatment are all vision dependent. And communicating to these people who are sitting in different places about the child's vision is a big problem. You may write long reports, but nobody reads them. You may try to hold a session to discuss, but it may never happen. So best is if all of them work as one team under one roof. What we follow in India in our CVI clinic is that the first time when the pediatric ophthalmologist does the vision assessment, the functional vision assessment, all the therapists watch and try to understand how the child sees. At the end of the session, the pediatric ophthalmologist ensures that all the physiotherapists, the speech therapists, special educator, they understand how the child sees. Then whatever therapies they do, they tailor it as per that vision. And we review the child as a whole once in a quarter to see how the child is progressing on different fronts. If one can build all the services under one roof, that is the ideal thing that is possible for the children. Vision intervention is a different science on its own with the master's and PhD degree programs. One can get trained into these, which involves significant amount of self-training, or we can visit people who are good at these things. So if one understands the vision and one also can do the interventions himself, that's the best possible thing for the child. But that may not be possible every time because we have to manage the time, we have our own priorities, and one should remember that one can do anything, but one cannot do everything. And that's the importance of building the team where each person can take care of a part of it. One can price it. Sustainability is very important. Otherwise, the program cannot run long. There is a big scope for philanthropy here because of the strong emotional appeal of this problem. So there are different ways that one can raise a support. One of the big problems over here, especially in the developing world, is that poor follow-up. They come to the clinic with high hopes and soon they realize that no, it's not going to work so quick. So then they lose the interest to follow up. Now, when with such people, one needs to be more compassionate because many parents take time to come in terms with the facts. It's not so easy to accept it. And different parents have different levels of motivation. It is always easily said than done, and they have their own set of issues. So we should not expect that any advice that is given is right away taken and implemented. They take time to really internalize that advice. So we should never make them feel guilty if they are non-compliant, but always be friendly, motivative, and compassionate. So to summarize the role of an ophthalmologist, we would say that diagnosis, identifying and managing treatable ophthalmic issues, good counseling, appropriate referral to other therapists, and saving the child from pseudotherapists is a must to do for any ophthalmologist or eye care professional. If one can do functional vision evaluation, it is good. If one can build a system which provides all the therapies under one roof, that is ideal. How far one wants to go, it is up to you. But one thing is sure, that even if you don't have the resources to begin with, all the resource and help will eventually follow if you really convince people properly. Mumbi, shall we move on, or you want to have any discussion in the middle?
Yes, I think you can rest a bit. I'd like to invite questions and comments from participants. Any clarifications? Any questions so far? Dr. Chatonda? Could you give us your yes?
Yes, thank you so much for the opportunity. Dr. Peheri, this is a great presentation, and we greatly appreciate it in the sense that I basically come from Malawi, and we have what I would say a naive system, which we are trying to build. And I think just talking about CVI, I would say that for many who are on this platform, I think it's just to encourage ourselves that we really have to strive to incorporate these principles and this knowledge into our modern day practice. Because in my little experience, I basically noted that after being exposed to this kind of information, it also becomes difficult when your colleagues do not actually appreciate the core knowledge in CVI. So sometimes you say one thing, and when the same patients go to a different doctor and they tell them a different story, it just becomes a big confusion. So I think it's just for us to be encouraged that we need to absorb this, we need to incorporate it in our practice. But this is a very great presentation and a very practical one.
Thank you so much, Dr. Chatonda.
Yeah.
Just one question. Looking at the scarcity of manpower that we have, what would you consider as the most important key personnel that we can incorporate in our system?
Yeah, Mummy, that's a great question, because I have seen children with CVI being managed in the developed part of the world, that is the UK and the US. Then we built a system in India, and now we are trying in West Africa. So we have to find solutions which are suitable for those conditions. Now, when we think of a scenario like Africa, the biggest challenge here is the manpower, the trained manpower. Now, the good thing about CVI is that this is not something that you need a medically trained person to manage. In fact, anybody with common sense can do these things. And there is nothing which can cause harm. So if we look for people who are really passionate to help the children, no matter what is their background training, we can train them to handle children with CVI. And not only CVI, but any child who is visually impaired. So we need to look at those kind of maybe paramedic people, or the best people I feel is the mothers of children who have this challenge, and they're really motivated to help their own child and similar other children. Now, how do we train them? One good thing that COVID has taught us is that a lot can happen online and there is no need to meet physically for several things. So we can actually organize more and more such sessions where we can train the interested people, and we can even take up some cases and discuss and plan. So Dr. Chatunda, I understand, is from Malawi. Yes, we can help children from Malawi sitting in Monrovia. Why not?
Yeah.
So I think that should be the approach looking forward.
There is a question here, and it reads, can you make a diagnosis of CVI in adults?
Yes, of course. CVI exists everywhere, but because I'm a pediatric ophthalmologist, I talk more about children. In adults, it is easier to diagnose because they are vocal about what they are going through. So it's easier to make a diagnosis in adult. In children, because they cannot explain what they see, it is harder. That's it.
Dr. Peheri.
Yes, Dr. Chatunda.
Just some two maybe questions. Just like again in my little experience, I noted a couple of patients which we kind of brought a diagnostic dilemma between amblyopia and CVI, and I was kind of thought that looking at the history and the risk factors is actually very helpful. I would want you to just make maybe a small comment on that. And then secondly, in some like developed systems, I'm aware that they do go up to the extent of involving teachers. Because, you know, as these kids grow, we would want to try and make them independent as much as possible. But I wanted to hear from your experience, how you, you know, beyond the therapists, how do you work with teachers, and is there anything that you would also, you know, advise us in Africa as we are developing the system?
Yeah, so amblyopia and CVI can coexist. Like say the child has a refractive error of -8 in both the eyes, which was not corrected for say 5 to 6 years of age. Yes, we need to make the child wear glasses and assess over a period of say 3 to 4 months, how is the child improving. And if suppose the vision improvement is not as expected, then we need to look for the cause. And if there is a history of say perinatal insult or any other acquired neurological ailment which involves the vision processing part of the brain that we have just discussed, then yes, we make a diagnosis of CVI. So to make a diagnosis of CVI, there has to be some history of neurological insult or any other neurological ailment which involves the vision processing part of the brain. So it can definitely coexist. And regarding teachers, other than parent, the second person who is most important in child's life is the teacher. Because as children grow, about 70-80% of the time they spend in the school. So the teacher has to be aware of the vision difficulties of the child and what kind of accommodations they need to make while teaching the child. This is very, very crucial. Because if the teacher doesn't understand, it is very easy for the child to be labeled as with intellectual impairment or learning disability, and he tends to get out of the school. Though he may have a good intellectual capability to cope with other children, but he needs a certain kind of environment and accommodations to continue in the regular school. So apart from the different therapists, we need to educate teachers very well about the issues, the challenges that CVI poses for children for learning things. We can organize such sessions for teachers as well online.
Is that a question, Dr. Sampa? You have your hand up.
Yes, yes, Dr. Mumbi.
Okay, so we'll get a question from Dr. Sampa, and then we'll continue. If there are any more questions, you can ask. We can ask at the end of the session.
Okay, so I asked a question earlier about whether we can make a diagnosis of CVI in adults, but maybe I just wanted to clarify what I meant. So we have those patients who have normal vision initially, and then maybe they suffer from something like a traumatic brain injury, maybe secondary to a road traffic accident. And when you examine their eyes, there's nothing, like there's no ocular damage, but they're unable to see. So we usually make a diagnosis of cortical blindness. So is cortical blindness the same as cerebral visual impairment, or are those two totally different things?
Yeah. So Dr. Samba, thanks for that question. Yes, if the ocular examination is normal and that doesn't explain the vision loss, yes, the seat of vision loss is the brain. Cortical vision loss is a specific entity which refers to the occipital lobe damage, either infarct or a structural damage because of trauma leading to vision loss. Uh, but apart from just occipital lobe damage, especially say stroke, which can involve any part of the brain, can cause very typical features of CVI. And one of the most common features is balance syndrome. So infarct, which is involving the posterior parietal lobes on both the sides, makes the patient clumsy in day-to-day activities. It makes the patient difficult to judge distances properly in the space, feels very confused while looking at people in the group, unable to recognize people when they're in group. So all these complaints which do not really fit into the ocular examination, one should suspect CVI. A lot of patients with stroke actually have CVI which doesn't get diagnosed. A lot of old people who have posterior parietal lobe atrophy because of Alzheimer's or any other degenerative process, they do have features of CVI. There are a lot of examples of people who have got very selective stroke involving the center of the brain which processes motion or which processes the area of temporal lobe which deals with facial recognition. And they have just those specific symptoms and they go unrecognized for years. So let me share a small example of a young man who used to work in Europe, and he suffered from stroke, and that is why he had to leave a very big position and come back to India, because they thought that now he won't be able to cope with his job overseas, so he should come back home. Now after he came home, they started realizing that though he is otherwise okay, he has significant difficulty while dealing with people. And he himself used to say that it takes me a long time to understand who is talking to me. And he was very intelligent. He had developed his own strategies to cope. That he used to look at the person's dress, the way he walks, and his voice, other things to understand who is that person. And the things reached a peak when he went once to the school to pick up his son, and the son was just next to him, and he couldn't recognize him. He had to ask the teacher, "Where is my son?" And the teacher said, "He is just next to you." And that's when he realized that something is wrong. He went to the neurologist and they said everything is okay, your stroke has resolved, probably you're anxious, and that is we are not able to uh, recognize people. But when we made him aware that this is nothing but prosopagnosia, that you cannot actually process faces, it is not that you cannot see faces, you can see them, but your brain is not able to make sense out of those facial images. And that is where his prosopagnosia was diagnosed, and he did have an infarct involving the temporal lobes. So yes, adults also do have CVI, but it often gets missed. And if we remember that framework of higher visual processing, it is possible to pick up CVI in any patient irrespective of age. Does that answer your question, Dr. Sampa?
Yes, thank you very much, Doc.
Okay, thank you very much. So I think we are moving to the second session. Yes, you may proceed, Doctor.
Okay. All right. So the next part is about the assessment and interventions. So far what we have done is more of theory. That is, what is CVI, why is it important, how does the brain see, what are the different symptoms that the patient can face, how do we diagnose, what is an ophthalmologist supposed to really do. Now let us come to the real assessment and interventions. Now we typically describes these things in two entities, that is low functioning CVI, where the child's vision is very, very low. That child may not even be able to look at the light. And high functioning CVI, where their visual acuity, visual field, they all are okay, but the child is not able to process and synthesize and use that information very well. That is called high functioning CVI. Now, it is really impossible to get into the details of these assessments and what exactly to do as intervention. Maybe it's a topic for another session, but we would just give an overview of how to go about it. Now, before going for any assessment or intervention, one must understand a few things like how to hold a child with cerebral palsy. This is very crucial because unless you make the child physically comfortable, you can do nothing with the child. If the child is always in pain and discomfort, there is no energy to use for vision. So if you have a child who is floppy, this is the way to hold. If you have a stiff and extended child, this is the way to hold, where you split the legs across the waist. And if you have a stiff and flexed child, this is the way to hold. So this makes them physically comfortable, makes them feel secure, and that is when can you do any vision assessment. It is very important to know this because many of our clinics in the developing world do not have those special chairs. Neither the parents nor our clinics have those chairs which can provide all these accommodations. But there are certain ways of holding the children which can serve a similar purpose. Many of the children tend to cry a lot when you try to examine them. One of the reasons is the sensory overstimulation because of the visual overstimulation, auditory overstimulation. We have just seen that many of the children have involvement of the posterior parietal lobes, which process the sensory information, not only visual but auditory, and tries to synthesize and map it out. When this part of the brain is injured, they are not really take in a lot of information at one time. So if you go to a very noisy place like a market or any other place where there is a lot of noise, a lot of people moving around, how do you feel? You feel irritated. You cannot really concentrate on what you want to do. And when you want to do something really in a focused way, you cut yourself from unnecessary noise and distractions. A child whose posterior parietal lobe is damaged has that problem for everything that he does. Anywhere there is too much to see, too much to hear, too much to feel, the child is frustrated. And the only way they can experience frustration is by crying. So we have to ensure that the place where they get examined, there is less to see and there is less to hear, which is quite contradictory to most of the examination rooms in the developing world, where we have a lot of things on examination rooms, a lot of people, a lot of activity and noise that is going on. So somehow we have to take care of that. So we have set up a vision assessment room in our clinic back in India, where we have this room in a corner without any decoration, plain walls, plain curtains, plain flooring, very few things which are neatly arranged in a cupboard, and we just take out things that we need at that point of time. We have in addition curtains so that any visitors or students who want to learn, they remain behind the curtains and just peep through rather than being around the child and increasing the visual clutter. We also have a facility to change the level of illumination. So that way we can take care of the visual and auditory overstimulation. Now, despite making those accommodations, if the child still is uncontrollably crying, that means child may have some physical cause for the pain. And that has to be looked for by a good pediatrician. Starting from headache because of raised intracranial pressure, dental caries, gingivitis, otitis, and undiagnosed corneal abrasion. joint pain, muscle spasms, contractures because of frequent seizures. One cause that we have found that it is often underdiagnosed is gastroesophageal reflux. A lot of the children suffer from reflux, and many of them even need surgery to correct that. Constipation, food intolerance, gallstones, urinary tract infections, kidney stones, pressure sores because their position is not changed for long times. All these can be the causes for why the child is crying. They should be addressed too. And only once we make the child comfortable, make sure the child has slept well, has been fed well, that you can go for assessment of vision. So this is just an outline of how do we really go about it. I have broken them into different pieces. First is the history. Ask the parents, what is it that really bothers them about the child's vision? Then comes the birth history. Is there any history of perinatal insult or anything that can suggest that the child may have had brain injury in the past? Look at the ophthalmic examination. What are the ophthalmic issues? And if there are any treatable issues, have they been addressed to adequately? Because unless these issues are tackled properly, whatever intervention you are going to do is of no use. If a child has an uncorrected refractive error, uncorrected hypoaccommodation, untreated cataract, there is no use of proceeding further anymore. First, we have to fix those issues adequately. Developmental milestones. How is the child doing in terms of the language development, motor development? What are the systemic comorbidities like hydrocephalus or epilepsy? How well it has been controlled? Because if they are uncontrolled, again, any intervention, not only vision, but any other intervention is just not going to work. Have an overview of other sensory issues. How is the child's hearing? What do parents feel? Can the child hear well? Because when a child is visually impaired, they are heavily dependent on sound, and we often use sound as an alternative sense for habilitating a child with visual impairment. But if the child is not able to hear well, it becomes a deaf-blind child, and the way you would habilitate such a child is going to be different. How does the child communicate? It is very important for us to understand that, because whatever we assess, we look for a response from the child. The vision assessment, field assessment, whatever it may be. We have to look for the child's response. And how does the child respond? How does the child communicate? Is the child verbal, pre-verbal, non-verbal? What is it? Is it through body language, head movement, eye movement? What is it? How are you going to judge a child's response? How does the child communicate with the parents? Parents will tell you how does the child communicate. And finally comes the neuroimaging. If the child has had a neuroimaging, have a look at it. But going for neuroimaging in each and every case may not be practical, may not be needed also. But if it is available, go through it. That will help us build a mental picture of what could be child's difficulties. Look at the overall condition of the child in terms of, is there any motor impairment? Many of the neurologists and physiotherapists, they would give the GMFCS scores, that is gross motor function score. And once you know the scores, you know what kind of motor impairment the child has. Like the GMFCS score is like 4 or 5. I understand the child is motor way really, really impaired. So the kind of responses that I would expect from the child during assessment or intervention are going to be really limited. Any visual impairment in terms of, the report that it says the visual acuity is how much. Any sensory issues, like does the child have hearing impairment, any issues related with the tactile sensations, any intellectual impairment. If the child is already known to have, say, a severe intellectual impairment, then the way you would expect responses from the child is going to be different. So having this overall idea about the child is a must before going in for assessment of visual functions. Because vision doesn't work in isolation. You need all these big apparatus that we have discussed a while ago. Without that, vision alone doesn't make any sense. And if you sit to assess the child's vision without knowing this background, you're likely to be lost. I have gone through that many times, and that is why I put this background of the child first, and then comes the visual assessment. One needs to have that base of the child's overall systemic condition. Now, when we look at the visual functions, the first and foremost things to look at is, does the child have any visual awareness? If there is no visual awareness, we go on a different track. But if there is some visual awareness, then we go on to assess it in more detail and try to quantify it. So we look at the visual acuity, field, contrast, color preference, latency, and span of visual attention. What are the tests used for that is not something that we can cover here, but these are the 7-8 must know things about any child's vision. Then we look at what does the child do using this vision. That means how is the child's eye-hand coordination? If you give him something, how does he really approach towards it? How is the visual search? If you show the child 4 or 5 things, how does the child really search and make out what is the thing of his interest? And while doing all this, how are his eye movement, the saccades and pursuits? So this forms the base of the child's visual processing. Okay. Then comes, how does the child use this vision in different areas of functioning? Now, when you say vision, it quite often so happens that they say that, oh, that child is moving around so nicely. What do you say he's not able to see well? I think he's just pretending. We fail to understand that the way one would use vision to move around is quite different from the way one would use vision for communication. To look at a person and recognize him, recognize facial expressions, respond in a particular way. So the use of vision for communication is quite different from use of vision for moving around. And use of vision for a sustained near task like reading or writing or drawing, anything of a near task is quite different from the vision that you use for moving around. So quite often these issues get confused. So we feel that we should look at vision under these 3 different headings, that vision for orientation and mobility, vision for communication, and vision for activities with sustained near task. And under each of these activities, we can then further grade the visual function as low, medium, or high functioning, depending on how much assistance is required to make that particular action happen. Like if a child has to look at a person's face, how much assistance you need to give in terms of contrast, the light, touch, and sound, that decides whether child is able to use his vision for looking at faces. Is it low level, medium level, high level? So that is going into the depth of the functional vision assessment in detail. And that completes the assessment of the child. Now, if you look at it in one go, it looks like it's just too much to do. But there is no shortcut. Unless you go this way, you are going to miss out things. And it is not necessary that one has to do everything in just one visit. You can split. It is always better to have little information which is reliable rather than trying to do too much in one go, which may not be possible looking at the concentration span and the energy levels of the child. So we can split things, do them in bits and parts, and accumulate meaningful information over a few months, complete the child's picture, and then go ahead with a definite intervention plan, which is based on the holistic picture of the child and not just 1 or 2 measurements here and there. Now, this assessment has to finally lead to some intervention. We are developing countries, we have limited resources and time, and whatever we do has to translate into some meaningful action. VEP is very good to assess vision of children with low functioning CVI, but who has it? None of us have VEP. And even if you have VEP, what do you really do with it? You can't design an intervention plan based on a VEP reading. So we assess things which really help in designing an intervention plan. Now, intervention plan has to be something that can become a part of the routine of the child. If for every intervention that you say, the parents have to travel to the base hospital, it is very unlikely to work because it's not going to continue for a long time. And if it is not a part of the routine of the child, it is unlikely to be followed for long, even at home. So we need to find out what are the routine activities of the child. So what are the usual routines of a child? Brushing, having milk, eating, playing, going for a walk, going to the shop. Pick up these usual routine activities and then think, how can you infuse vision into these activities? How can we use the information that we have just learned from the assessments to make these day-to-day activities more meaningful for the child so that child can participate in day-to-day life? That is real intervention. And all this has to be parent-centered, something that is designed for the parent to use, something that they really understand, something that they can really do with the resources they have. So any difficulty that we have, we should follow this approach of why, how, and what. Suppose the child has difficulty in looking at faces while communicating. That's the difficulty parents come with. Ask yourself, why is it happening? Is it because of a high refractive error or a cataract? Or if all ocular examination is fine, it's quite possible that the child has CVI. So what component of CVI? Is it an occipital lobe damage that can cause poor acuity? No. His acuity is okay. Fine. Then move on to the next. Posterior parietal lobe. What posterior parietal lobe problem can cause difficulty looking at the faces? Simultanagnosia. Probably if there are too many people around, child is unable to look at the face. But if it is only one person, he can. Yes, then probably it is simultanagnosia, that a child is not able to look at people when there are too many people around. Fine. No, that's not the case. Even if it is one person, he can't. Then what it could be? It could be a temporal lobe damage. So even if it is one person, his temporal lobe is just not able to match that face with any other face in its imagery. So that is classical prosopagnosia, right? So we need to think from all these perspectives and find out why. Why is the child not able to look at the face? Once you understand that why, the next thing is to understand how. Now, how can I work around it? Suppose it is because of occipital lobe damage. How can I make the face look, face be more accessible? Go closer, approach magnification. Things look bigger and that can make things visible. What is the other strategy? Enhance the contrast. If you enhance the contrast, things may become visible. Make them more colorful, of the color that the child really likes. It may become visible. Those are the strategies if occipital lobe is damaged. If it is because of a parietal lobe issue, make the environment simple. Don't have too many people around. Don't have a distractive background. Don't have too much sound around. And the child should be able to look at the face now. If it is a temporal lobe problem, then any of these accommodations are less likely to work. So we have to look at alternate strategies of recognizing the person, which could be in terms of the voice, a particular scent, or a style of clothes, a style of greeting the child. So we have to bring in all those alternative mechanisms of recognizing the person. So that is the what. So that will tell you exactly what is to be done. So what is to be done cannot be understood unless we know why something is happening, and in principle, how that difficulty can be worked around. So that is what we call as why, how, and what approach. If we go from out to in, that is what, how, and why, it is unlikely to work. But if you go from first why and then what, that tends to work. So we should have this framework always in our mind while dealing with children or adults with brain damage and vision related issues. Just taking one example of how do we translate the assessment into an intervention plan. Like to understand the visual acuity, one of the commonly used tests is the Leah paddles, where we have these alternate dark and white bands, teller acuity cards, and we check to which side does the child look at and what is the smallest line width that the child can look at. Now, you found that on the Leah paddles, the child's visual acuity is 4 cycles per degree, or at 40 centimeters, or Taylor Acuity told you that it is 20 by 200. Now, putting that number in the paper or telling the parent that the child's visual acuity is 20 by 200, it means that what a person can see from 200 feet, the child will have to go at a distance of 20 feet to see it. Does it make any sense to the parent? If it doesn't, then whatever assessment you have done has no meaning to the family. Then how do we really make it understandable to the family? So what we generally do is compare the line thickness that the child could appreciate in terms of the finger thickness. Like this one is quite similar to the thickness of an index finger. This is half the index finger. We tell the mother that whatever detail you show the child, make sure that those details are of at least this width, and there is a gap of this much between the two details. Taking an example of, say, you want to feed the child milk. So this bottle, which is plastic and transparent, you can make it visible by putting these alternate bands. This red color band, which has a shining material on it, separated by the distance of this, and the width of the tape is also equal to the width of this dark and white band. And we put it against a black background so that the color is enhanced. We show this in a dark room. And when there is milk inside, you move the milk, that adds the component of movement to it. That milk also has taste and smell. So everything now comes together. The vision, the smell, the taste, and also one can sing a song, which kind of complements that experience. And that is how one makes this experience of feeding the milk accessible by using the information that we got from Leah patterns. So that is how whatever we assess becomes an intervention and becomes a part of the routine of the child, so that the parents do not have to dedicate any extra time to do what we suggest. So like that, we do the same for visual acuity, accommodation, visual field, contrast sensitivity, color preference, latency and attention span, eye movements, and we also look for evidence of blind sight. We cannot go in details of each of these, but those are the usual parameters that we assess. Now, what do we do with this information? Explain to the mother and ensure that the thresholds are understood. It may not be possible that they can take in everything at once, but one or two things, explain them well, explain them how to use it at home, and then go slowly. There is no time to go into intervention, but there is one thing that I would like to clarify is that many people tend to believe that showing bright lights or something colorful and moving in a dark room is going to awaken the vision. So the stimulation of vision to me sounds like there is a dead dog and I'm trying to poke that dog to wake up. No, that's not how we deal with vision. How does the brain really work? Though we have divided brain into different parts for vision and touch and hearing and so many things, actually brain works as one unit. Each of the center is connected and interdependent with several other parts of the brain. And when one part is not working well, other parts tend to come in to help that part. We cannot ignore this fact when we are intervening a child with visual impairment. We must remember that the touch, hearing, smell, a lot of all those senses are trying to come in to help the child to see things, may not be in the conventional way of seeing, but to make him understand what is going on in the external world. And we have to make use of all those senses. So stimulation classically means watching passively high contrast objects in a dark room. And this is actually counterproductive because that doesn't give the brain opportunity to bring in other senses to make the child understand the world. But what is important is the intervention, which is dynamic and interactive approach, where the instructor chooses the stimuli as per the responses of the child and tailors them as per the responses. And that is a more meaningful activity than just showing lights in the dark room. Like this girl. Examiner holds an illuminated ball. So she is not able to look at anything. So we made the room dark, chose a simple ball of yellow color, which is her favorite color, without any details on it. We illuminated it. So it becomes high contrast, simple object. We made her to touch it, feel it, and pronounced its name in a very slow way gave her the time to feel it, hear it, understand it, and now she's engaged. So that is what we call as multisensory learning. And the way we are pronouncing it, because she is not able to see the lip movements and the face movements, we make those movements more coarse, more exaggerated, and the child feels all those things with her hands. So that is how we help the child understand what is a ball. So this is much more engaging to the child rather than just showing that ball in a dark room passively. Now, this is the book that I mentioned at the beginning, developed by one very good pediatrician in India, Dr. Amar Parsha. And I have given this book to Mumbai. He can forward it to all of you. That tells you a real set of activities that one can do at home, going by the constraints of a developing world, and depending on the vision skill, the level at which the child is, what should be done. This book will tell you that. This book was actually meant for uh, children with just visual impairment without a brain component to it. But still, a lot of those activities make sense. We have developed a similar manual just for children with brain injury. It is not yet officially out, but I can share it with you at the end of the class. Now, it is very important that we share the information with the other therapists that we just discussed, and then we can discuss about innovative ways of how to incorporate vision into their therapy so that things are done around the same time. Like, child may not have separate time for vision and physio and this and that, but you can actually design activities in such a way that all these things go hand in hand. So about intervention, first one should make the child and when we have to make ourselves and the child comfortable. Before vision, understand the child as a whole and assess the thresholds of vision and explain those to the parents, teachers, and therapists. Make them part of the routine and forget about vision stimulation. Try to make things more meaningful and uh, something part of the routine. Okay. Now, the last comes the high functioning CVI. We have touched upon some part of it. These are the different terms like high functioning CVI, perceptual visual impairment, cognitive visual dysfunction, vision processing related disorders. They all mean the same. And that is their primary visual functions, that is the visual acuity, visual fields. They all are normal or near normal, but they have issues with visual processing. Now, the diagnosis of these disorders basically happens through history taking. So in the beginning, we have enumerated 8-9 complaints that point towards a visual processing related issue. But the best way to go about this is by using a certain set of questionnaire or inventory so that you don't miss on any part of visual processing. And once you really go through it and process it, you can give parents a set of strategies for each of these difficulties. So again, all this is a topic for a separate discussion, so I will not go into those details, but just giving an idea as to this is how we go about it. Now, so history is a cornerstone, but there are certain clinical tests that one can do. Clinical tests for high functioning CVI is a developing area. Nobody really has those robust tests with high sensitivity and specificity, like say applanation tonometry, visual field analysis for glaucoma. No, we don't have. But there are a few things which we have found useful over a period of time, and we do those. Neuropsychological evaluation, if available, is good, but is most of the times it is not available, and we have to go more by history. There are a few neuropsychological conditions that mimic CVI very closely, and first and foremost in that is the autism. Then comes the attention deficit hyperactivity disorder, intellectual impairment, and specific learning disability. How to differentiate one from the other is again beyond the scope of this class. But here comes the need for a very close interaction between the psychiatrist or the psychologist and the ophthalmologist. It is not unusual for one thing getting labeled as the other one, depending on who saw the child first. And it is very crucial to understand the implications of the label that we put. Once you say a child is autistic, the whole approach of the whole society towards that child changes. Once you say the child is learning disability, the way the whole education system is going to look at the child is going to be different. And the vision processing issues may never be thought and addressed. So it's very important that we all work in tandem about children with these overlaps. So the take-home message about high functioning CVI is that it is significantly disabling, but highly underdiagnosed. And the cornerstone of diagnosis is good history taking. Clinical tests are not really robust, they're evolving, but nevertheless, they are useful. So before sending away any family telling that the child's eyes are normal, think of high functioning CVI. Go into neurological history, ask these complaints. And even if you are not able to do anything, at least giving parents an explanation of what is happening and what can be done about it brings a lot of relief to the family. And their attitude towards the child, the way they look at him and behave with him, all those things can bring about a lot of change by our diagnosis. So these are the things that we tried to look at today. I hope it wasn't too exhaustive. Mumbi, I'm done and we can go for discussion.
Thank you very much for your time and being quite very exhaustive in the presentation. We have overshot a bit, unfortunately, I think by 10 minutes or so. We started off late. I'll invite just a few comments and then we'll close. If there are others who are unable to verbally ask, you can still send your questions in the Q&A here. Any comments? As comments are coming up, I just wanted you to comment how you distinguish delayed visual maturation versus CVI.
Yeah, that's a very commonly, we commonly come across this confusion. So for delayed visual maturation, number one, they may or may not have history of neurological impairment. So DVM, delayed visual maturation, has 3 types. So in that, type 1 is without any ocular or neurological abnormality. If there is ocular or neurological abnormality, that is type 2 and type 3. So it is the type 1 where we often tend to confuse. The distinguishing feature of DVM and CVI is that DVM tends to respond more rapidly. Like in a few weeks' time, the child will cope up and come at par with other children. But CVI typically takes a longer time. If you really want to differentiate further, you can go for a VEP. VEP often shows poor or subnormal results in case of CVI, but in DVM, it tends to be more closer to normal values. So DVM is actually a diagnosis in retrospect. On first visit, you can't differentiate the two. But you follow up and you see that, oh, this child now has picked up very well and is at par with his other children at same age, then it was more of DVM and not CVI.
Okay, thank you. I'm not seeing any questions yet.
Okay.
Unless I'm missing out anyone with a raised hand. Yes, so far there are no questions. Any comments from participants? Any clarifications you would want to get further? Yes, Dr. Niranjan, I think your presentation has been exhaustive. I'm not seeing, oh, there's a hand raised from Dr. Musiwa. Okay, just allow her to talk. Yes, Dr. Musiwa, you may proceed with your question.
Good evening, Doc. Thank you so
Hello.
much for the presentation. I think it's very exhaustive, and this I've really appreciated what I've learned so far. I just want to ask on the photo stimulation. We tell our patients when they go home, we tell the mother to the child, we describe how to do the photo stimulation. So now I want to find out from your experience, what is the, I don't know if I can ask, is the correct method or dosage, or for how many minutes, how many hours, how many times a day do we tell the mothers to the children to practice that photo stimulation? Like, what is the best number of times to do that to get a very good result. Thank you.
Okay, well, Dr. Musiwa, thank you so much for that question. Did you say that you advise photostimulation?
Yes.
Yeah. So what does that really involve?
So in our setup, in our practice, we do have these. Sometimes we just tell the mothers to the children to use just a bright light, like in a dark room, and then to just try and stimulate, like they can use that. But then that light may not be sufficient because they've got different light sources, or so they're not the same. But then there are times that they buy in the pharmacies. They have these photostimulators, this bright photostimulating lights that they are able to use. But then I just want to find out, like, what is the correct way of asking, or what is the correct amount or quantity, or what's the number of times that they should be able to practice use that?
Well, the simple answer to that question is we should discourage such practices, because that doesn't make any sense to the child. Like if there are any colorful lights just moving around the room, and earlier the child was not looking at anything, but over a period of time you see that the child is looking at the lights. But what does it really mean to the child? Does it create any memory in the child's mind about that thing? Because intervention is about teaching the child something. And what is teaching or learning? Learning is about creating a meaningful memory of an experience. So by showing these colorful lights moving around, the child doesn't actually store a meaningful memory of that experience. It's just there are lights and he looks at it, that's it. That cannot be called as an intervention. But the same thing if you do in a more meaningful way, like there is a stainless steel spoon and you put light on it in a dark room, child looks at it, feels it, puts it in his mouth. So along with vision, you have used touch, you have used taste. Now on that spoon, you put a little drop of honey and make the child taste it. Now taste also comes into play. So now we are doing something like a multimodal stimulation. Now next time, when you show the spoon, the child's responsibility to put it in his mouth. Now the child has a memory that I saw something like this earlier and it tasted very nicely. So probably this is something that I can put in my mouth. So I would encourage more of such activities in a dark room involving touch, vision, taste, smell, create a memory, and that is more appropriate rather than just the photo stimulation. And this activity should continue throughout the day, any number of times depending upon the level of energy of the child and the mother.
Okay.
Yeah. So this looks like there's a similar question also that was asked in relation to what you have just answered. I think the only difference she used photo stimulation, and Dr. Njuguna is asking, the question is on visual stimulation. I'm assuming this should be in line, Dr. Niranjan, if you have seen the question, which is saying how long do you visual stimulate? Example, 1 year before you stop. Does this sound like a similar, the previous question I've just answered?
Yeah. Well, I won't say there is any upper limit to which you can keep doing interventions, because we know that brain is plastic for quite a few years, even into adult life. So I would say we should continue doing these interventions till late teen age. And because I have seen a few children who were not doing so well in the early part of their life, but a time came when they just took off. And maybe that was because their intellectual ability grew with time and they were able to assimilate what is being done, and then they took off. So I will not put any mark of 6 months or 1 year to which you do it. But one thing is certain, that the initial few months are very crucial. That is kind of a make or break kind of situation. In those 6 months, we must ensure that the activities are something that the family can do, the child also likes and is engaged. So initial 6 months are crucial. but there is no upper limit as to which you can go on intervening.
Okay, so in this case, do you get lesser response? We normally believe that that neuroplasticity goes on up to the age of 7. So in terms of response, do you expect lesser response in someone who is older compared with someone, say, who's around 5?
Yeah, well, certainly the maximum neuroplasticity is till the age of 7 to 8 years, as far as vision is concerned. But plasticity is different for different functions. And there is a nice book by Dr. Norman Deutsch about how brain heals itself. And in that, he describes some exceptional cases of adults who have got over their significant neurological disabilities following certain techniques of neuroplasticity. So if it can exist even in adults to that level that they can get over a disability, I don't think we should deny intervention for any child because they have crossed that age of 7 to 8 years of plasticity. We should continue.
Okay, thank you. Dr. George, you may proceed with your question.
Good evening, everyone. Good evening, Dr. Niranjan, Dr. Mubi. Hi. Thank you so much for this great lecture, Dr. Niranjan. If we look back, some of the causes of CVI, they are also medical, including brain infections such as meningitis. So my question, comment, what I want to get clarification from is that if the meningitis is treated, especially like in Africa, in our region, we see some of those patients in pediatric or with meningitis. If the meningitis is treated, can the CVI also be resolved if the CVI is actually due to the meningitis?
Yes, George, you're absolutely right. Any child with any brain disease is at a risk of CVI.
Okay.
And meningitis, encephalitis, these are all established causes of CVI. What happens in many of these meningitis or encephalitis is they may have these exudates which settle down. And if you look at the place where they would settle down, would be somewhere here. That is the posterior parietal lobes and maybe some part of the temporal lobes. So I would say that any child with treated meningitis, encephalitis has to be screened for CVI. And one more condition that is more prevalent here is the cerebral malaria. So all the children with brain infections are potential candidates for CVI and they have to be assessed for it once their acute illness is taken care of. Does that answer your question, George?
Dr. George, was your question answered?
Yes, thank you so much.
Okay,
Okay,
thank you.
George is my resident in Monrovia.
Ah, great.
Yeah.
Yes, so before we close, there's one more question from Dr. Malemane. The question is, isn't there a risk of stimulation overload when you stimulate hearing, sight, and taste during the intervention sessions?
Yeah, you're absolutely right. I'm so glad that this question has come up. So every child is different. So that is what intervention is about, where the instructor looks at the child's response and then tailors his intervention. So if you see that, if I add sound, touch, and all the elements, child is becoming more irritable. That means probably his posterior parietal lobe is not able to take in all these inputs. Try once, twice, on different occasions, trying to change the situation. If the child is still not able to engage in that kind of activity, then probably you're dealing with a child who is not able to take in multiple stimuli at the same time. He is more of a one thing at a time kind of a person, and you should go that way. So yes, you have to individualize, and that is what is intervention against stimulation.
Okay, thank you very much. It has been a pleasant session. We really appreciate, and we have learned a lot. hopefully we'll start changing our practice, and that's especially on making a diagnosis. I think that's one of the drawbacks that we do. Most of these patients, we feel like they're really wasting our time when the patients come. We do very quickly. And then I just wanted to comment that most of the patients that we see, I've seen patients as CVI, and yet we have not bothered to do a few things that have been described, like refraction. Psychopathological refraction is very important, that you rehabilitate the vision. Whatever residual vision is there, we try to give a correction as much as possible. Okay?
Yeah.
Yes, so any closing remarks, Dr. Niranjan, as we close?
Well, I'm really happy that we connected with people from different countries today. We have shared some ideas, and it is very important that we keep this dialogue going. So I would really encourage people coming up with some cases and training sessions, and I would be very happy to, help whomever we come across.
Okay, so would you mind sharing your contacts? Colleagues asking they can keep in touch with you.
Sure.
Okay.
Well, Mumbi, I'll send you my email. You have my email ID.
Yes.
So, I'll give you my WhatsApp number as well, and you can share it with everyone.
And just to mention to everyone, I've seen that there's a request, a session coming up on CVI from OBIS. I saw that from the email that you're also presenting on a similar topic with OBIS. This should be in the first week of September.
Yes.
Yes, so I would encourage everyone to make that registration with OBIS, and you can join in again.
Yeah. So that session is more focused on interventions.
Okay.
So for those who have attended today, it would be more beneficial because you have the background information now.
Okay, thank you very much, everyone, and bye-bye.
Okay, bye everybody.
Bye.
Everyone, thank you so much.
Thanks everyone.
Mm.